Welcome to the 2020 NHSN Training Webinar. Today, we will discuss the Patient Safety Component Protocol and Annual Facility Survey updates. This is the agenda for today's presentation. Hi, I am Dominique Godfrey, and the title of my presentation is Out with the Old, In with the New. Guidelines for non-culture-based testing to meet laboratory-confirmed bloodstream infection or LCBI criteria. I am one of the subject matter experts responsible for the bloodstream infections chapter. During today's presentation, we will discuss the 2020 updates to LCBI criteria and the 2020 Central Line Associated Bloodstream Infection or CLABSI exclusions. Before we begin today's presentation, I would like to provide this disclaimer. The appearance of any product or brand names in this training is for educational purposes only and is not meant to serve as an official endorsement of any such product or brand by the Centers for Disease Control and Prevention or the United States government. CDC and the United States government, by mentioning any particular product or brand, is neither recommending that product or brand nor recommending against the products or brand's use. The purpose of this webinar is to share the 2020 updates on the use of non-culture-based testing to meet laboratory-confirmed bloodstream infection criteria and to review the Central Line Associated Bloodstream Infection exclusions. Throughout the presentation, I will refer to non-culture-based testing as NCT, laboratory-confirmed bloodstream infections as LCBI, and Central Line Associated Bloodstream Infections as CLABSI. So let's begin with the objectives. At the completion of the webinar, you will know the following: changes to LCBI criteria from 2019 to 2020, examples of how to meet LCBI-1 Criterion in 2020 using NCT methodology, examples of how to meet LCBI-2 Criterion in 2020 using a culture, the CLABSI exclusions for 2020, and how to report the CLABSI exclusions to NHSN. This is a lot of information to take in, so let's begin. Let's take a few minutes to discuss the why behind the 2020 LCBI definitional changes. So why were changes made to LCBI criteria? The decision to make changes in the criteria was in response to questions and/or concerns from infection preventionists and other frontline staff performing surveillance for healthcare-associated infections, or HAIs. The time frame included in the LCBI-1 definition was added because some NCTs are intended by manufacturers to be accompanied by a companion blood culture. For example, there are some NCTs where the instructions for use state a blood culture also should be collected when an NCT was used and a recognized pathogen identified. Additionally, as many of you may know, the advancements in technology and the use of NCT methodologies added another level of complexity to the BSI criteria. There were questions to consider when an NCT was used. Some of these questions included: does a positive NCT alone meet LCBI-1 criterion? In 2019, the answer to this question was yes. A single positive NCT result would have met LCBI-1 criterion. Another question to consider was: is bacteremia suspected, or is there another source of infection? Through discussions, it was determined that the clinical intent for using an NCT was not always to identify a bloodstream infection. In some instances, the test was used to diagnose an infection at another site or to identify a specific pathogen targeted for antimicrobial therapy. Given this, the NHSN team decided further guidance was needed when an NCT was used and a pathogen was identified. Before we continue with the criteria, updates, and examples, let's review a couple of key definitions that are important to understanding and applying LCBI-1 2, and 3 criteria. I will begin by discussing the definition of culture-based testing. What is meant by the term culture-based testing? NHSN defines culturing as a laboratory process that requires a specimen to be inoculated into culture media, incubated, and observed for actual growth of microorganisms. This process can take several days or weeks to report a final result. The length of time is dependent upon the organism identified. An example is the use of blood collection bottles as a culture media. Now let's turn our attention to non-culture-based testing. Non-culture-based testing refers to identification of microorganisms directly from a blood specimen using methods such as genomic sequencing or magnetic resonance assays. The key to an NCT is there is not a culture of a blood specimen from a plate or culture media. Some examples of NCT methodologies that NHSN has seen most often in user questions include Carius and T2 magnetic resonance. I would like to take a brief moment to discuss another NCT frequently submitted in user questions, Fungitel. While Fungitel is a type of NCT, in 2020 it is no longer eligible for use to meet LCBI-1 Criterion. The reason for this is because the updated LCBI-1 definition requires that a bacterial or fungal pathogen is identified to the genus or species level. The Fungitel test provides either a positive or negative result. Because the definition is not fully met, meaning the identification is not to the genus or species level, this test is no longer eligible to meet LCBI-1 criterion in 2020. This guidance differs from the guidance provided in 2019. We will now take a look into the past, review the 2019 definitions, and compare them to the 2020 updates. I will begin with LCBI-1 criterion. In 2019, LCBI-1 criterion was met if a patient of any age had a recognized bacterial or fungal pathogen not included on the common commensal list identified from one or more blood specimens obtained by a culture or non-culture based microbiologic methods. Additional requirements were the organisms identified in the blood were not related to an infection at another site. On the next slide, you will see the testing methodology is further defined when an NCT is used. In 2020, the first part of the definition remains the same. A patient of any age must have a recognized bacterial or fungal pathogen not included on the common commensal list identified from one or more blood specimens by culture or non-culture based testing. However, there is additional guidance provided on non-culture based testing which states the organism must be identified to the genus or species level by NCT methods. There is also a note which provides a time frame and guidance for the accompanying blood culture. Additionally, the organism or organisms identified in the blood is not related to an infection at another site. Let's take a few seconds to absorb LCBI-1 criterion before we move to the 2019 LCBI-2 criterion. So in order to fully meet LCBI-2 criterion in 2019, a patient of any age must have at least one sign or symptom noted on the slide in an organism or organisms identified in the blood that was not related to an infection at another site, and the same common commensal is identified by a culture or non-culture based testing method from two or more blood specimens collected on separate occasions. As we review the 2020 definition on the next slide, you will note the first two elements used to meet criterion are the same. They are: a patient of any age must have at least one sign or symptom noted on the slide, and an organism or organisms identified in the blood that is not related to an infection at another site. However, in 2020, the common commensal is identified by culture from 2 or more blood specimens collected on separate occasions. The 2019 LCBI-3 definition is similar to the 2019 LCBI-2 definition, with the exception of the age requirement of the patient as less than or equal to 1 year and specific signs or symptoms for this age group. Note, in 2019, the same common commensal is identified by culture or non-culture based testing method from 2 or more blood specimens collected on separate occasions. Moving to the 2020 LCBI-3 definition, this definition is similar to the 2020 LCBI-2 definition, with the exception of the age requirement of the patient as less than or equal to 1 year and specific signs or symptoms for this age group. Again, in 2020, the common commensal is identified by culture from 2 or more blood specimens collected on separate occasions. Now that we have reviewed LCBI criteria, let's look at some examples of how to meet the definitions, starting with LCBI-1 Criterion. In the first example, I will review meeting the 2019 LCBI-1 definition. On 2/6, there is a positive blood culture for Staphylococcus aureus. The positive culture was set the date of event, and the infection window period is 2/3 through 2/9. A BSI repeat infection time frame, or RIT, is established from 2/6 through 2/19. Placement of the central line is considered access, so the central line day count for making a CLABSI determination will begin on 2/4. On the date of event, 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. This is a CLABSI event because there was an eligible central line in place on the date of event. Please note, this same determination also would apply in 2020 because LCBI-1 criterion is met using a positive blood culture. Let's look at the rationale for this determination. Because Staphylococcus aureus is a recognized pathogen, LCBI-1 criterion is met. No other criteria, such as signs or symptoms, are needed to meet LCBI-1 criterion. Let's move to the first example using the 2020 LCBI-1 definition. In this example, there is a positive NCT for Staphylococcus aureus on 2/5. On the next day, 2/6, there is also a positive blood culture for Staphylococcus aureus. LCBI-1 criterion is met on 2/6. Again, the positive culture was set the date of event. The infection window period is 2/3 through 2/9, and a BSI RIT is established from 2/6 through 2/19. Placement of the central line is considered access, so the central line day count for making a CLABSI determination will begin on 2/4. On the date of event, 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. This is a CLABSI event because there was an eligible central line on the date of event. The rationale for this determination is because a positive blood culture is collected within the 2 days before or the 1 day after the positive NCT, the NCT is disregarded. The only result used is the positive culture result for Staphylococcus aureus. The matching organisms identified by NCT and culture has no impact on the date of event. In this example, a different organism, Enterobacter cloacae, is identified by NCT on 2/5, and Staphylococcus aureus is identified by culture on 2/6. The date of event is still set by the positive culture on 2/6. The infection window period is 2/3 through 2/9, and a BSI RIT is established from 2/6 through 2/19. The central line is inserted on 2/4, so this is considered the first date of access for making a CLABSI determination. On the date of event 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. This is a CLABSI event because there was an eligible central line in place on the date of event. The rationale for this determination is because the positive blood culture is collected within the 2 days before or 1 day after the positive NCT, the NCT is disregarded. The only result used is the positive culture for Staphylococcus aureus. The identification of Enterobacter cloacae by NCT would not be reported as a pathogen for this event, nor would it change the date of event since the NCT result is disregarded. In this example, the only positive result is the positive NCT for Staphylococcus aureus on 2/7. So LCBI-1 criterion is met on 2/7. This result will set your date of event, and the infection window period is 2/4 through 2/10. A BSI-RIT is established from 2/7 through 2/20. The central line day count for making a CLABSI determination begins on 2/4. On the date of event 2/7, the central line was in place for 4 calendar days, 2/4 through 2/7. This is a CLABSI event because there was an eligible central line in place on the date of event. The rationale for this determination is because there is no positive blood culture collected within 2 days before or 1 day after the positive NCT. The positive NCT result identifying Staphylococcus aureus is used. In this last LCBI-1 example, there is a positive blood culture for Staphylococcus aureus on 2/6. This positive culture will set the date of event. The infection window period is 2/3 through 2/9, and a BSI-RIT is established from 2/6 through 2/19. During the BSI-RIT, there is a positive NCT result for Enterobacter cloacae. Because the collection date is during the BSI-RIT, this event is reported with both Staphylococcus aureus and Enterobacter cloacae as the organisms. Additionally, on the date of event 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. Therefore, this is a CLABSI event because there was an eligible central line in place on the date of event. The rationale for this determination is the positive NCT collection date occurs in the BSI-RIT, and Enterobacter cloacae is identified. There is no blood culture collected within the 2 days before or 1 day after the positive NCT, so the Enterobacter cloacae is not disregarded, but added to the initial LCBI-1 event. Now I will discuss how to meet LCBI-2 or LCBI-3 criterion in 2020 and compare this guidance to that provided in 2019. As a reminder, in 2019, LCBI-2 criterion was met using culture or non-culture based testing methods. In this example, there is a positive blood culture on 2/6 for Staphylococcus epidermidis, a positive NCT on 2/7 for Staphylococcus epidermidis, and a fever on 2/8. LCBI-2 criterion is met on 2/6 since the positive blood culture is the first element used to meet criterion. The infection window period is 2/3 through 2/9, and a BSI-RIT is established from 2/6 through 2/19. Placement of the central line is considered access, so the central line day count for making a CLABSI determination will begin on 2/4. On the date of event 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. This is a CLABSI event because there was an eligible central line in place on the date of event. The rationale for this determination is because companion tests, the positive blood culture and the positive NCT, identify Staphylococcus epidermidis, and there is a fever in the infection window period, LCBI-2 criterion is met. In 2020, this same determination will not apply. The guidance for testing in 2020 is the common commensal is identified by culture from 2 or more blood specimens collected on separate occasions. In this example, there is a positive culture for Staphylococcus epidermidis on 2/6 and a positive NCT for Staphylococcus epidermidis on 2/7. Because the guidance states the same NHSN common commensal must be identified by a culture from 2 or more blood specimens collected on separate occasions, LCBI-2 criterion is not met. Let's look at the rationale. Although fever is documented during the IWP, the positive NCT result is not used as a companion culture. Only a single common commensal is identified by culture. Per NHSN guidance, the single culture result is considered a contaminant and not eligible for use to meet LCBI-2 criterion. Similar to the LCBI-2 definition, in 2019, the 2019 LCBI-3 definition could be met using culture or non-culture based testing methods. In this example, there are blood cultures on 2/6 positive for Staphylococcus hominis, a positive NCT on 2/7 for Staphylococcus hominis, and apnea on 2/8. All elements occurred during the infection window period. LCBI-3 criterion is met on 2/6 since the positive blood culture is the first element used to meet criterion. The infection window period is 2/3 through 2/9, and a BSI RIT is established from 2/6 through 2/19. On the date of event, 2/6, the central line was in place for 3 calendar days, 2/4 through 2/6. This is a CLABSI event because there was an eligible central line in place on the date of event. In this example, the positive NCT result is not used in the final determination because companion cultures of Staphylococcus hominis are collected on 2/6 and there is apnea in the infection window period. The last example for LCBI-3 criterion has a positive blood culture and positive NCT. The guidance for testing in 2020 is the common commensal is identified by culture from 2 or more blood specimens collected on separate occasions. In this example, there is a positive blood culture for Staphylococcus hominis on 2/6 and a positive NCT for Staphylococcus hominis on 2/7. As a result, LCBI-3 criterion is not met. Although apnea is documented during the infection window period, the positive NCT result is not used as a companion culture, so there is only a single common commensal identified by culture. Per NHSN guidance, the single culture result is considered a contaminant. This is the last example showing how to apply the 2020 definitions. Before we move to the CLABSI exclusions, I would like to provide a few pearls regarding non-culture-based testing. I recommend that you highlight or star the next couple of slides. The information provided on these slides can serve as a guide when applying the 2020 LCBI definitions. The first 3 pearls are NCT methodology is only used to meet LCBI-1 criterion. Test results from NCT methodologies are only available for use in meeting LCBI-1 criterion when the organism is identified to the genus or species level. Culture-based testing is the only testing method used to meet LCBI-2 or LCBI-3 criterion. NCT is not used. And the last 2 pearls are related to the BSI RIT and secondary BSI attribution. When the NCT specimen collection date occurs in the repeat infection time frame, an organism identified by NCT is only added to the event if the organism is a recognized pathogen and there is no blood culture collected within the 2 days before or 1 day after the NCT. The NCT may still be used for criteria of some site-specific infections. If an NCT is used to identify an organism in blood for one of the other sites of infection and the other requirements of the secondary BSI guide are met, the BSI may be attributed as secondary. So I have reviewed the 2020 LCBI criteria updates and provided examples of how LCBI criteria is met. The last part of the presentation will focus on the CLABSI exclusions and reporting each exclusion to NHSN. I will begin with some important points to remember. When reviewing a CLABSI exclusion, it is important to remember all CLABSI exclusions require that an eligible central line has been in place for more than 2 consecutive calendar days on the BSI date of event and still in place on the BSI date of event or the day before. Reporting of these events to NHSN is required in 2020. However, when met, these events are not included in the CLABSI event data that are sent to CMS. Additionally, when an exclusion is met, the event is considered an LCBI, but is not considered central line associated, even if a central line is present. The central line field is marked yes if an eligible central line was in place for more than 2 consecutive calendar days on the BSI date of event and still in place on the BSI date of event or the day before. When each exclusion is met, a subsequent blood specimen resulting in a BSI with a date of event outside of the BSI RIT must be investigated and meet the CLABSI exclusion criteria again in a new BSI IWP in order to determine that it is not central line associated. Lastly, meeting LCBI criteria will result in setting a BSI RIT, and you should include any associated device days in the counts for the denominator summary data. Let's begin with a review of each CLABSI exclusion, starting with extracorporeal life support, ECMO, or ventricular assist devices, VADs. In this exclusion, a BSI meeting LCBI criteria with an eligible central line where ECMO or a VAD is present for more than 2 days on the BSI date of event and still in place on the date of event or the day before will be considered an LCBI. When this occurs, report such events marking the central line field yes and the ECMO or VAD field as yes. The next exclusion, patient injection, is met when a BSI meeting LCBI criteria is accompanied by documentation of observed or suspected patient injection into the vascular access line within the BSI IWP. The event is considered an LCBI, but not a CLABSI. When met, these events are reported. This event is reported as a CLABSI exclusion for patient injection, marking the patient injection field as yes and the central line field as yes. Next, we will move to the epidermolysis bullosa, EB, or Munchausen syndrome by proxy, MS-BP exclusions, followed by pus at the vascular access site. The EB exclusion states there must be documentation of EB during the current admission. Similarly, the MSBP exclusion requires documentation of known or suspected MSBP during the current admission. Additionally, both exclusions require the presence of a central line for more than 2 days on the BSI date of event, and the central line must still be in place on the date of event or the day before. If met, these events are reported by marking the EB or MSBP field as yes and the central line field as yes. The last CLABSI exclusion I will review is pus at the vascular access site. To meet this exclusion, the patient must have both a central line and another vascular access device, pus at the other site, and a specimen collected from the other access site must have at least one matching organism to an organism identified in the blood. If met, the pus at the vascular access site field is marked yes. The central line field also is marked yes if the central line is present for more than 2 days on the BSI date of event and still in place on the date of event or the day before. This slide provides a list of vascular access devices included in this exclusion. Before I conclude the presentation, I would like to provide a quick note about the Group B Streptococcus CLABSI exclusion. This exclusion is limited to a positive Group B strep culture with a date of event during the first 6 days of life. When this occurs, the event is not reported as a CLABSI. However, there is a BSI RIT set, and any associated device days are included in the counts for denominator summary data. The NHSN application will not allow this event to be saved. To summarize a few key points from the presentation, NCT methodology is only used to meet LCBI-1 Criterion. Culture-based testing is the only testing method used to meet LCBI-2 or LCBI-3 Criterion. And lastly, reporting of all CLABSI exclusions to NHSN is required in 2020. This concludes this portion of the 2020 updates on the use of non-culture-based testing to meet LCBI criteria and the review of the CLABSI exclusions. I will now turn the presentation over to my colleague, LaTosha Powell.
Thank you, Dominique. Hello, my name is LaTosha Powell. I'm one of the BSI subject matter experts here at NHSN. I will be providing a couple of updates regarding the MBI-LCBI criteria. So by the end of this section of the presentation, our viewers will be able to explain the MBI-LCBI 2 and 3 clarification regarding non-culture-based testing, and summarize the pathogen assignment exception related to the MBI-LCBI events. First, I would like to provide a clarification related to the MBI-LCBI table found on page 4-10. As Dominique Godfrey previously shared, non-culture-based testing, or NCT, is not eligible for LCBI-2 or 3. Because patients must first meet LCBI-2 or 3 criteria before meeting MBI-LCBI-2 or 3 criteria, and since those criteria no longer include NCT, NCTs cannot be used to meet MBI-LCBI-2 or 3 criteria. A revised table will be published in the 2021 BSI protocol. Now we're going to move on to an exception related to the pathogen assignment during BSI RIT of an MBI-LCBI event. On the left side of this slide, I'm highlighting a rule for pathogen assignment that reads as follows. BSI pathogens may be assigned to more than one infection source at the same time in the following scenarios. 1. The secondary BSI pathogen is assigned to two different site-specific infections, or the secondary BSI pathogen is assigned to a site-specific infection and assigned to a primary BSI event. To the right of your screen, you'll see an example of how option 2, denoted by the red arrow, is applied. This example can be found on page 2-19. On hospital day 4, a Staph aureus blood culture is identified and meets LCBI-1 Criterion. On day 8, the patient spikes a fever, and on day 9, there's a greater than 100 K of E. coli identified in a urine culture meeting a SUDI criterion. On day 16, an E. coli blood culture is collected. Because the blood culture occurs within both the LCBI-RIT and the SUDI secondary BSI attribution period, the E. coli blood culture is assigned to both events. So let's take a look at an example that involves an MBI-LCBI RIT. On day 6, MBI-LCBI-1 is cited using the Enterococcus blood culture and the eligible ANC levels to meet the neutropenia element. Additionally, on day 6, a skin 2A is cited using the erythema, swelling, and a positive skin culture. Again, I want to highlight the pathogen assignment rule denoted by the red arrow. A day 16 Staph aureus blood culture is collected and is deemed secondary to a skin 2A because it matches the organism from the skin culture used to cite the skin 2A, and it's collected during the day 6 through day 19 secondary BSI attribution period. However, Staph aureus is a non-MBI organism. According to the pathogen assignment rule, the Staph aureus blood culture must be assigned to the SBAP and the BSI-RIT of the MBI-LCBI event. However, when you assign a non-MBI organism to the BSI-RIT of an MBI-LCBI-1 event, you must change the designation from an MBI-LCBI-1 to an LCBI-1. We have heard about rare cases where it's necessary to change the MBI-LCBI event to an LCBI, even though there was another site-specific infection clinically that the non-MBI organism could be attributed to. We agree that this was not the intent of the surveillance rules. As a result, an exception was made to the pathogen assignment rules. The exception can be found on page 2-17 and also page 4-15. So let's apply the new MBI-LCBI BSI-RIT exception using this scenario from the previous slide. So on day 6, an MBI-LCBI-1 is cited using the Enterococcus blood culture and the eligible ANC levels to meet the neutropenia element. Additionally, a skin 2A is also cited on day 6 using the erythema, swelling, and positive skin culture. A day 16 Staph aureus blood culture is collected and deemed secondary to the skin 2A because it matches the organism from the skin culture used to cite the skin 2A and collected during the day 6 through day 19 SBAP. The Staph aureus blood culture is a non-MBI organism. However, because of the exception in 2020, the Staph aureus blood culture is assigned only to the SBAP and not the BSI-RIT of the MBI-LCBI event. And as a result, the MBI-LCBI designation remains the same. There's a similar example that can be found on page 2-20. So here's a quick summary of the 2020 BSI protocol updates. NCT methodology is only used to meet LCBI-1 criterion. Positive blood culture results from culture-based testing is the only testing methodology used to meet LCBI-2 and/or LCBI-3. NCT testing is not eligible to cite an MBI-LCBI-2 or 3. A non-MBI organism blood culture does not have to be assigned to the BSI-RIT of an MBI-LCBI event if this blood specimen is deemed secondary to an NHSN site-specific infection. And finally, all BSIs meeting a CLABSI exclusion in 2020 are reportable to NHSN with the exception of the GBS exclusion. This concludes the 2020 BSI updates. I will now turn the presentation over to my colleague, Victoria Russo.
Hi, my name is Victoria Russo, and I am the primary subject matter expert for surgical site infection, or SSI, event surveillance on the protocol and validation team. Today I will provide updates made within the 2020 SSI protocol related to the denominator for procedure detail scope and the SSI event detail infection present at time of surgery, also known as PATOS. Now let's talk about updates related to scope. As a reminder, scope is a required data field on the denominator for procedure form. ICD-10 PCS codes can be helpful in answering the scope question. Scope is defined as an instrument used to reach and visualize the interior of a body cavity or organ site of the operative procedure performed. NHSN operative procedures performed using a laparoscope, you would indicate scope equals yes. Because the fifth character of the ICD-10 PCS code indicates the approach to reach the procedure site, for 2020, NHSN updated the ICD-10 PCS scope designation table, which can be found within the SSI protocol, to better assist users with answering the scope question. Additionally, clarification has been provided within the 2020 SSI protocol related to CPT codes in answering the scope question. For CPT codes, the scope question can be answered based on the procedure code description, which is provided within the CPT code guidance documents. Using HIST code 58570 as an example, the procedure code description indicates laparoscopy, surgical with total hysterectomy. Procedure descriptions that include laparoscopy are scope equals yes, so therefore in this example you would indicate scope equals yes. Now let's talk about updates related to PATOS. As a reminder, PATOS is a required field that's found on the SSI event form. SSI Event Reporting Instruction Number 3 was updated for 2020 to provide clarification related to application of PATOS. PATOS denotes that there is evidence of infection visualized or seen during the surgical procedure to which the SSI is attributed. An abscess is considered evidence of infection. Therefore, the term abscess is provided as an example of evidence of infection within this instruction. Additionally, a note has been added to the PATOS instruction to reinforce that wound class cannot be used for PATOS determination. A high wound class does not necessarily mean that PATOS would equal yes. And finally, clarification has been made to state that the evidence of infection must be noted intraoperatively and documented within the narrative portion of the operative note or report of surgery. Let's talk a little more about this on the next slide. Because we have received several questions related to the areas within the operative report that can be used to answer the scope question, NHSN felt we needed to formalize within the protocol that the narrative portion of the operative note or report of surgery can only be used when answering the PATOS question. Just a pre- or post-op diagnosis alone without documentation of infection seen within the operative narrative or findings is not sufficient for use when answering the PATOS question. Additionally, there must be clear documentation that reflects the tissue level where the infection is seen, and this should be reflected within this narrative. The 2020 FAQ will be updated to reflect this clarification, and as of note, the PATOS Quick Learn has been updated for 2020 as well. So definitely check that out. So that concludes my updates for 2020, and I'm going to go ahead and turn over the presentation to Agasha Amor.
Thank you, Victoria. My name is Agasha Moore. I'm part of the NHSN survey team, and today I'll be talking to you about the 2019 Patient Safety Component Annual Survey changes and updates. But first, I would like to go over a gentle reminder. The CMS Q3 reporting deadline will be on February 18th, 2020, and it falls on the 18th because the 15th is a Saturday. And we recommend that you complete the annual survey before the CMS deadline so that your data are risk adjusted using the matching survey year. If your survey is not completed by the February 18th deadline, your data will be analyzed using the most current completed survey for SIR risk adjustment. The next reminder I'd like to bring up is March 1st. This is the deadline to complete the annual survey in the NHSN application. If your survey is not completed by March 1st, then you will not be able to complete the monthly reporting plans in NHSN. Next is a data quality opportunity that the NHSN is providing. So the NHSN annual survey team will be conducting data quality for any of the variables that you put into your annual survey for SIR risk adjustment. There's a table up here that shows what variables we'll be looking at. So I will be looking at facility bed size, patient days, admissions, ICU bed size, medical school affiliation, teaching status, single occupancy rooms, ventilator dependence admissions, hemodialysis admissions, LTAC settings, orthopedic condition admissions, traumatic spinal cord dysfunction admissions, non-traumatic spinal cord dysfunction admissions, stroke admissions, and ARF setting variables. And these variables are used for SIR and SUR risk adjustment. What we'll be looking at is comparing your previous survey entries and the current year survey entries to see if there are any significant changes. Please look forward to our outreach emails where we'll be asking you to confirm your data. And if it is correct, please let us know. If you've made a change, please let us know too. Next is the 2019 Patient Safety Component Annual Survey changes. So fortunately, this survey year has had minimal changes as compared to the 2018 annual survey changes. We have some additions of questions, some clarifications, and 2 retired questions in the neonatal patient practice section and the antibiotic stewardship practice sections. So for the facility neonatal patient care practices and neonatal admission information section, you will notice that on question 25, there has been more clarification to the not applicable answer option. This option now reads, not applicable, my facility does not provide neonatal or newborn patient care services at any level. That is to say, my facility does not provide delivery services, level 1 well-born care, level 2 special care, or neonatal intensive care. Also in this section, you will notice that the old question, question 30, which was a new question in 2018, has now been retired and has been replaced with the question here, which reads, if babies are roomed with their mother in the labor and delivery or postpartum ward, they are administered oral or perinatal antimicrobial such as ampicillin. What location is the medication administration attributed to in the electronic medication admission record system or barcode medication administration system? And this question has been updated to provide better understanding of your facility's practices and protocols for administering antimicrobials to newborns. Next, in the antibiotic stewardship practice section, you will notice that a sub-question to question 35 has also been changed slightly for more clarification. The question 35A now reads, if selected, our stewardship team audits antibiotic orders to review appropriateness indications. You also notice that question 38, Clostridium difficile, has been changed to Clostridioides difficile, and this was to match the current literature. Question 43 in the antibiotic stewardship practice section has also been retired. The question used to read, our facility has a clinical decision support tool embedded in the electronic health record for antibiotic use or stewardship interventions available to prescribers. And last but not least, there's been some minor changes to the water management program section. Since 43 was retired, all the numbers changed for the water management program section. So question 51 is now question 50, question 52 is now question 51, and so on and so forth. But you will notice that the questions for question 50 now reads, have you conducted a facility risk assessment to identify where Legionella and other opportunistic waterborne pathogens could grow and spread in the facility water system? And question 51 now reads, does your facility have a water management program to prevent the growth and transmission of Legionella and other opportunistic waterborne pathogens? And so these questions are not necessarily changed, it's just that the wording has changed slightly. Also, lastly, question 51, which was previously 52, has now added some extra options for you to select when considering what personnel are involved in your water management program. Water management program. And so I have highlighted those changes on this slide. You can now check leadership, maintenance staff, equipment, chemical acquisition supplier, safety officer, consultant, or laboratory staff. And this concludes the changes to the annual patient safety component surveys and protocol changes. Thank you for listening. Are there any questions?